Neelam, can we start?
Yes.
Good afternoon. Welcome to the third webinar by AMR Declaration Trust. AMR Declaration Trust is a public charitable trust founded on the principles of Chennai Declaration. Our primary objective is to stimulate discussion and action and explore Indian innovation and ideas to tackle the global challenge of antimicrobial resistance. AMR Declaration has minimal funds. We have received small donations from doctors. However, our resources is not adequate to conduct academic activities. We decided not to charge any registration fee to spread the message to a broader audience. We are grateful to the doctors who gave their small donation to the trust and pharmaceutical companies such as Sanofi, Galanjan, Converge Biotech, Alniche, Viatris, who have provided us with small unrestricted educational grants for the webinar. And we have requested a few companies like Cipla, Pfizer, Gufic, and we are expecting grants from these companies as well. The webinar, our strategies to implement a successful antimicrobial stewardship program in our hospitals, will discuss the challenges we face in implementing AMS and infection control programs and the innovative strategies Indian hospitals devise to overcome these challenges. Antimicrobial resistance is a global challenge. There is no doubt India has one of the highest AMR rates in the world. That said, Indian hospitals are the healthcare destination for the world. The high AMR rates in the country makes us more vigilant and we strategize. We believe in providing the best service based on the available resources. We have high-profile private hospitals whose standard is as good or better than the best centers in the West. We have top institutions under central government. We have thousands of hospitals of varying sizes under the state government. Despite several challenges, these centers indeed serve the mass. We find a way to translate the AMS and infection control success stories of our top hospitals to other centers in the country, adapting to the available resources in the center. All top hospitals in the country today have excellent prototypes of antimicrobial stewardship. We built these success stories because of years of sincere and incremental teamwork. Now let us give a helping hand to all the healthcare institutions in the country. Let us share our experiences, challenges, and how we overcome these challenges. We have senior management figures from both private and government hospitals attending this webinar. We will have two panel discussion sessions. And the first session is, every challenge is a gift. Without them, we wouldn't grow. We have Dr. Sunil Kedarpal, who is the Director of Association of Healthcare Providers of India, and AHPI has endorsed this webinar. Thanks a lot to AHPI. We have Dr. Narayani Shivakumar, who is a Zonal Director, Mumbai Fortis Healthcare. We have Dr. Ellen Kumaran, who is the CEO of Rela Institute, which is a famous liver transplant center in the country. We have Dr. Uma Nambia, who is the chairperson of Digital Healthcare India Association. We have Dr. Sahadullah, who is a chairman of the KIMS Healthcare Group. We have Dr. Anup Warrior, who is the chief of medical services, Aster Medicity Kochi. Anup is also a trustee of our AMR Declaration Trust. Dr. Anup?
Yes, sir.
You are an infectious diseases physician. You are also one of the trustees of our AMR Declaration Trust. May I ask you, are doctors responsible for the AMR crisis?
If you want the whole blame to be placed on somebody, I wouldn't agree to that, because all of us are well aware this is a much larger problem out here, and very unfair to put the complete blame on a single group of people. However, when it comes to obviously the streamline of use, and we do have a role, because end of the day, as prescribers, we are the ones who write these antibiotics in our outpatient practice and our inpatient practice. So in the limited setting where we have control, that right. So I feel there is much we can do in that sphere where we have control. However, I would disagree with the complete blame being placed on a single category like doctors.
Yeah, because it's a broader problem, a socio-economic challenge, and we doctors use only a part of the antibiotics manufactured by the pharmaceutical industry. 70% of the antibiotic is utilized in the animal farming, and our rest of the 30%, half of it is over-the-counter sale of antibiotic without prescription. We doctors use only 15% of the antibiotics manufactured by the pharmaceutical industry. And we know that bugs are spreading in the community, sanitation issues, and it's a real socio-economic challenge that we all need to tackle together rather than just the doctors and the medical community. Dr. Kedar Pal, sir,
Yes,
you
yes.
represent AHPI. What is your opinion on the impact of AMR to our hospitals and our patients from an economic, morbidity, and mortality perspective?
Yeah, first of all, I would like to congratulate AMR Declaration Trust, especially Dr. Abdul Ghafoor, for organizing this webinar, which will serve as an initial brainstorming sessions to further develop the strategies to tackle the menace of AMR. This program is, of course, endorsed by AHPI. I thank Dr. Ghafoor for giving us an opportunity to be a part of this webinar and share our views on important but most neglected topic. I think very rightly, the very valid question you have put up. Now, AMR, as we have discussed, is a great socio-economic challenge that needs to be tackled by all sections of society, and all stakeholders should be involved. Now, antimicrobial resistance has a great impact on hospitals, patients, and society at large. Even WHO has declared that AMR is one of the top 10 global public health threats which is facing the humanity. And AMR undoubtedly causes a great strain on the health system. And the economic impact, when we talk of the economic impact, the cost of AMR to the economy is significantly huge. According to the World Bank, an additional 24 million people, most of them in poor countries, will be forced into poverty by 2030 due to the cost of hospitals visits and arising out of the antibiotic resistance. And unfortunately, most of the increase would occur in the low-income countries. Also, there has been a study which is published in the Lancet Infectious Diseases in August 2014. It's an 9 years old study, which reported that BRICS countries like Brazil, Russia, India, China, and South Africa, they consumed 76% of the overall increase in global antibiotic consumption between 2000 to 2010, and of which India contributed 23%. So huge contribution by India. And in India, antimicrobial alone contributed to 16.8% of the total medicines sales in the year 2014 and 2015. So the estimate suggests that the per capita antibiotic consumption in India increased by around 22% between 2012 and 2016. And though antibiotic consumption rates in India are still lower as compared to Europe, there is increased use of newer class of antibiotics, such as carbapenems, third generation cephalosporins, and penicillins with beta-lactamase inhibitors. So these economic impact is huge. And also the economic impact of increasing AMR rates is now on the top of the global agenda, not only because of the health security threats, but also because of the severe economic consequences. Now, when I talk of the impact on the hospitals and patients, in addition to the death and disability, that is mortality and morbidity, the prolonged illness results in longer hospital stays, that ALO has increased the average length of stay, shorter turnover, which is affecting the hospital revenue, and the cost of high-end investigations and requirement of more intensive care beds, isolation beds, and spent on more expensive medicine and financial challenges for those who are impacted with AMR. So these are the increased direct healthcare costs on account of the antimicrobial resistance. Other indirect costs would include people not engaging in economic activities by taking longer time off from the work, absence from the work, reduced quality of life, and greater likelihood of death. So these can be summarized as the impacts of AMR on society at large, both health and economics.
Thank you, Dr. Sunil. I'm just clarifying because I'm a clinician and you are a healthcare management expert. And for the clarity of the audience, hospitals prefer short hospital stay and higher turnover.
Absolutely.
And if the hospital stays prolonged, and that's not good even for a hospital perspective.
That's what I said. Yes, I mentioned the same thing. Yes.
Thank you. So thank you, Dr. Sunil. And Dr. Saadullah, you're the chairman of a leading corporate hospital group and a strong supporter of antimicrobial stewardship and infection control program. How often the topic of AMR, antimicrobial stewardship and infection control, is discussed in your highly privileged group of hospital owners and directors?
Yeah, good afternoon to everyone, and I'm very happy that for your efforts, Gafur, in this direction. I really appreciate your trust as well as your activities. About your question, I will say that it's very rarely discussed, and there are other P&L issues and so many other things are discussed when the CEOs and the owners meet. The main reason I would say that why infection control or AMR or AMS and all do not come into the discussion because of the lack of awareness among the owners. Actually, if the owners, most of the owners are not doctors. And this is why always I say that the doctors should come into management. And at the moment, many of them are not even quite aware such AMR and all that exist. And then another factor they don't want to address is that they think that it will add cost. It will add to the cost of the patient care, and so their margins will come down. So generally, there's a lack of awareness. We conducted a few meetings in the just before COVID and one after COVID to make the owners aware. I'm not saying about the doctors; that's a different effort altogether. The owners and the CEOs who are not doctors, to make them aware the importance. So a general lack of awareness on the government side as well as on the public and the private hospital owners side is standing out prominent. And our efforts, I'm also support your efforts certainly, and should be directed in really promoting the awareness among this, and that may make a difference. That's my answer. Thank you, Dr. Gafur.
Thank you, Dr. Saadullah. We have Dr. Narayani Shivakumar, who is the CEO of Fortis. Ma'am, Fortis Hospital Group have done excellent work in the field of antimicrobial stewardship. How do you convince those senior doctors who don't follow the AMS policies of the hospital? Because it's a problem in all hospitals.
Sorry. So yes, it is a problem in all hospitals. But I would say that from the time we launched it, it is at least a problem which we all look at with the same degree of intensity from the management side as well as the clinician side. And there are a couple of things which are, I would say, key to the fact that we've got the clinicians involved. One is when we started this whole program, we had the clinicians actively part of it, and the whole manner of launching it, the clinicians are a part of the whole discussion and how we planned the AMS program initially. And this is something which we track on a monthly basis. There are distinct to our prophylaxis, the usage of antibiotics, the usage of restricted antibiotics, the strict protocols, and we track this on a monthly basis, and we discuss this with the clinicians. We do have instances when they don't want to follow the protocols, but here we, couple of reasons which we feel why they won't want is they think, I mean, sometimes they're not very convinced that the simple antibiotic would take care of the infections, and they're so worried about the patient outcome. In all such instances, we have elaborate conversations with them with data to show that the simple antibiotics do work. And in very resistant cases, we actually bring in another clinician who may have a track record of no infections, very good outcomes, and complete compliance to the prophylaxis and lesser usage of antibiotics, and get them to convince. Largely, I would say this is working well for us. Every now and then we have this little outlier with 1 or 2 specialties, but going back and talking to them does help us. So I personally think that we have an environment where the clinicians also have a buy-in. We have a strong focus on that. Do we have some more distance to go? Yes, we have some more distance to go. Does it take some convincing of the clinicians? Yes. Is it an impossible task? No. Is it, does it defeat us? Not really. And I feel, I mean, we do make progress, but it's something which is very much there as part of our discussion every month.
Thank you, ma'am. No hospital has got 100% compliance. I work at Apollo Cancer Institute for last 15 years, and we have got a very good program, but compliance is never 100%. And I think no hospital in the world has 100% compliance. We have 80-85% compliance, and I believe it's very good. I'm sure you've got same level of compliance. There will be always few outliers, and still, the progress that we make is more important. We have Dr. Ilan Kumaramurthy from Rella Hospital. Dr. Rella was supposed to join, but he's held up in the liver transplant case. When we do all the international discussions of antimicrobial resistance and all, the Western countries, especially the UK system, say we have a uniform system of antimicrobial stewardship and infection control, but countries like India do not have such a uniform system. What are the strengths and weakness compared to of our healthcare system compared to that of a country like United Kingdom? Dr. Ilan, what do you think about it?
Thank you, Dr. Kapoor. Good afternoon to all of you. I have worked in the UK as an intensivist and anesthetist for nearly 6 years before coming to India and started working with Professor Rela for the last 13 years. And we have been doing very high-end work like liver transplantation in our center. So we know the major difference between UK system and the Indian system. UK system, NHS, even though there are hundreds of hospitals, comes under National Health Services, it's considered as a single unit. There are local protocols, local guidelines, centralized guidelines, which are all governed by a central body on a regular basis. And each NHS trust allocates a significant funding to monitor these kind of activities to ensure AMS is properly followed. We know the system in India. There is a gross major difference between the UK system and the Indian healthcare system. And we are all growing over the period of time. And we have government system, private system, where there are a number of huge hospitals doing high-end work, like us, who does nearly 300 liver transplantations, serving both national and international patients. So if you look at the difference, there are hospitals in our country which are all NABH and JC accredited, which almost have the same practice of what we used to do in the NHS, and we provide equivalent result of transplant surgeries and any other high-end surgeries. We are able to replicate the same exact model or outcome of what we used to do in the National Health Service system, because we are able to put system in place, including AMS. So we have a team of AMS who does regular auditing, rounds, monitoring, and then do day-to-day rounds to control all these activities. So which says that even in our country, if we follow the protocols properly, we should be able to replicate the same results. It's possible. We can do it. At the same time, the people working in each unit should have the mindset, both the management and also senior doctors, they should have the mindset of adapting these kind of changes. I think that's a need of the hour in our country.
Thank you, Dr. Ilan. Yeah, so you made the point, because our country has got a bigger challenge. We have got 1.3 billion population. We have got 100,000 hospitals, 1 million doctors, not a uniform healthcare system. But UK is just a small country. The population is that of Tamil Nadu, and countries like Sweden is, the size of the population or the number of the hospital is probably less than one district in our country. And we have got a bigger challenge. And despite all those challenges, we do very well. Especially the big centers do very well. We need more hand-holding of the small centers, no doubt about it. The clinical outcome of all our good hospitals is as good or even better than any of the international centers. Dr. Anup?
Yes.
What specific challenge you experienced in implementing AMS program in your center from a management perspective? And what was your out-of-the-box solution? You are an ID physician and director of medical service. I'm sure you have faced a lot of challenges, and being an ID physician has helped you to overcome that solution to the challenges.
Over the last, say, 15 years or so, I had an opportunity to work in different kinds of management styles or management settings. Initially I had the opportunity in a more of an autocratic style of management, then a democratic style of management, and now finally I am in a situation where we are following the participatory style of management. So in all these three, the challenges or difficulties which you would face in implementing certain policies are much different and very difficult. End of all this, the thing which is most sustainable and what we are working with now is more of a participatory kind of thing. If you want to list out the challenges, primarily the first challenge is to get people who are confident and who can gain the trust of the prescribers. When you act as an evangelist for AMR prevention or for stewardship and you want to advocate good prescription practices, you need somebody in your system whom the rest of your prescribers respect, trust, and are willing to listen and go along with. So that is one of the biggest challenges. You need, because you can think of systems and system management, etc., but end of the day, it boils down to having the right kind of people in the right place, running the show. That's very, very important. And that's the first challenge is that get people who are able to build consensus, engage with the prescribers, take them along and make a successful case out of stewardship. The second, this thing is more practical, that even when you are the steward yourself, still you face challenges when there are umpteen number of situations, clinical scenarios, situations where there are no clear answers. Your ability to put your foot down in terms of evidence, so-called published evidence or guidelines, etc., is very, very limited in those scenarios. And hence, even though you may have a gut feeling against using antibiotics or cutting down on antibiotics, etc., you still need to go with the rest of them because we have not generated that kind of evidence in that scenario per se. So just narrowing it down to two major things. One is about having the people who are competent to drive it on the ground. And two is to have enough clinical evidences for certain practices which we advocate or profess for the stewardship.
Thank you, Dr. Anup. So, you mentioned about the democratic system and the participatory system. Can you explain, because, to the audience, what will be the difference? Because all these approaches are very important for the antimicrobial stewardship strategies. Everything depends on strategies. We all read guidelines, same protocol, but the implementation is all dependent on the local strategies. So please explain for the audience.
So we could have multiple kinds of engaging or modalities of engaging people. So the autocratic is where you have the rule laid down and you have a way of enforcing the rule top down, and people are expected to toe that line and do that thing. But that's very, very difficult. It's a very, very limited situations where that is possible in our setting at all. So that's why we come down to this democratic and participatory kind of thing. So the democratic way was where when I joined the organization, we initiated with that kind of thing where we used to take inputs, we used to discuss with people and get their inputs primarily and try to get everybody on board and have a consensus policy, etc. The problem with that is, one, it takes an inordinate amount of time, and two, to get 10 people agree on something becomes extremely difficult, right? Especially 10 doctors and all. And three, even when you take the inputs, and this is seen from our state antibiotic policy or many other state policies, etc., that when you have democratically you take inputs from specialists, orthopedicians, gynecologists, etc. What they want comes out, and not what really you want, or what is the evidence, or what is the best practice, right? So it gets diluted. While in the participatory thing, you are able to influence these in a way that you work along with them and they work along with you. So you are accepted as a partner in clinical care, and antibiotic prescription is a part of clinical care, and you are a part of that clinical care, and hence you are acting as one clinical team in delivering that particular, treating that particular infectious episode. Hence, there is no pressure, or there is no this thing of taking their consensus, getting ideas from them, asking them what antibiotic you want to prescribe. No, you have built a partnership where they trust you to take care of that infectious episode, and hence you are able to put in best practices, and they go along because they trust you as a team. So they are, we are both working together for the same management. So that's how the last part works. I don't know whether I have made myself clear.
Yeah. Thank you, Anup. That's really useful. Especially probably a combination of all these factors could be useful based on the setup. In very small setup, very small specialized units, some level of autocracy will be useful. And the same, of course, democracy and participation are very important. Based on the setups, we have to define and identify our own strategies. But it was very useful explanation.
Just to add, Dr. Ghaffur, like what you're so just a last word on this. Now, to implement this participatory sort of thing, obviously from the management level, you require some kind of a nudge, and that in our setup, this is where we put in systems for mandatory ID referrals or ID input. So, right, in most of the settings, what we see that, say, a liver transplant surgeon or an intensivist, they would have to put an active referral to have an infectious disease person or an AMS team inputs into that. As I was mentioning, we are focusing on making this a part of clinical care. So that means wherever there is a specific requirement of high-end antibiotics, culture positives, etc., the ID physician or the AMS team should be an inherent part. And to make that happen, the management can have a policy of mandatory ID consults or referrals, or insist that for these kind of setting, 1, 2, 3, this kind of patients, the ID physician or the AMS team would be co-managing or would be a part of active clinical management. So that's how this works on the ground.
Oh, thank you, Anup. That's a very good, very good explanation of the different levels of antibiotics stewardship strategies. Dr. Saadullah, what specific challenge you faced in your center and how you tackle those challenges? Because we all have AMS challenges every day, in daily consultation, and the long-term strategies. What are the special challenges that you faced?
Yeah, I think as Anup explained to some extent, I think among, you asked me earlier about among the owners and the CEOs, but the same thing exists even among the doctors and consultants. And even I will say, even the ID physicians are not properly informed about, there is a lack of knowledge how to implement these things. And mainly because one thing is we have got a fixed group of doctors, and the other reason is that floating a postgraduate population in bigger hospitals. And then, of course, a mindset when many people have, oh, what do this ID physician know, which I do not know about? And so that's the kind of thing. So what we have approached is that management commitment. That's the most important thing, as we have said. This is an important subject. Even though like in the US, SSIs and HAIs are not honored by the insurance, that policy is not here. I wish it will come. We have approached it as a very systematically. The first thing is we have a Kim's Health formulary, and the antibiotics can be prescribed only from that one. So a full compliance is there on, and it's completely automated, and only through EMR and CPOE we prescribe. Second thing, a good microbiology lab. and who by digitalization, the data is available, the resistant antibiotic based on the site of infection, etc., is readily available online to the physician. So they can, choose the antibiotic and from the antibiogram or whatever we have submitted. So we started out. So it's an antibiotic culture which we have to develop in prescribing, and that's what we have to look at it. For example, the prophylactic use of antibiotic in elective surgeries, and that has been started from day one. In fact, I'm coming from the JCI background, and and it has been very successful. In fact, as you said, 100% is not always there, but it is at least 80 to 90% in dosage, in the usage, in the time, everything we have achieved. So consistent practice and auditing by a clinical pharmacist is one of the most important things which we can apply. Then empirical antibiotic therapy comes. That is another challenge which we have to. And so we have tried all the methods, and that is where many times we cannot. The ID team, we have got a very strong ID department, and they go and definitely they go and audit every month. Last month actually it was E&D department auditing the previous month. So every month a system of auditing is there, and we share that with the people of that department, and they definitely make the changes. And of course, escalation, de-escalation, and also goes. Another thing which we tried is that some restriction in the antibiotic prescription. This comes from the background. I worked in the previous hospitals I worked, and we have practiced as an internist. I have been always responsible for some of the selective. For example, now what we do is prescribing restricted, antibiotic. For example, general third generation cephalosporins or carbapenems or polymyxin, etc. can be prescribed except the first dose only by the ID physician. And it has worked very well. And so that we have more or less kept it, available for a very difficult situation. So I think, a number of factors together should work on this one. And participation of the physicians and the consultants is required, and we do that through various sessions and consensus sessions. But eventually, we have to have a policy for the hospital if you really want to achieve in a reasonable time, and especially when you do transplants and liver transplants and pancreas transplants and all that, you should have a good policy. Otherwise, we are always volume dependent, Dr. Kapoor. We make survival only by a number of patients increase. In the Western world, it may not be that much, and the visitors are less, and so SSIs are much less, and all that. So I think we should have to have a policy for every hospital depending upon their appetite and their challenges.
Thank you, Dr. Sahadul. Again, we're all stressing that in India, we face more challenges than in the Western hospital, but that also makes us more vigilant and strong in tackling antimicrobial resistance and hospital-acquired infections. And also, Dr. Sahadul, you mentioned about clinical pharmacists. We have got Dr. Grace Mary John, who is president of Association of Clinical Pharmacists. And, clinical pharmacists have received 6 years of training, on the contrary to the D Pharms who have got 2 years of training. And, we have got a big team of clinical pharmacists in our hospital. And, they are helping us a lot in antimicrobial stewardship. Dr. Grace, how can you, clinical pharmacist, and you are the first qualified infectious disease clinical pharmacist in the country. How can your team and your society can help all our hospitals in implementing antimicrobial stewardship?
Thank you, sir. Thank you for your question. Like everybody was saying, like all the administrators have already stressed upon the fact that India is different from the Western world when it comes to the numbers, when it comes to the numbers of patients. And we need a huge workforce to ensure that the stewardship activities are continued. And I think that's the most important aspect where clinical pharmacists can come in, because if you take a hospital which is like a 300 bedded or a 500 bedded hospital, as per the CDC data, in the Western world itself, they are saying 50% of the antibiotics that are prescribed are inappropriate. So, who is going to take care of in a 500 bedded hospital 250 cases or 250 prescriptions? Who is going to go on a daily basis and see which patient is getting the right antibiotic or the appropriateness of the medication therapy? So, in that regard, if you have a good clinical pharmacy team that helps you with the data collection, especially in India, all the hospitals are struggling with the medical records, because still now every hospital does not have a computer automated or a fully automated medical record. Most of them are still manual. So all these things adds on to the work pressure, and a lot of workforce is needed. And if you take our hospital, so I work in Believers Church Medical College Hospital, so we do not have a full-time ID physician with us. So in that case, I think we are the first Indian hospital to have a clinical pharmacist run antimicrobial stewardship program. So when we have the dearth of ID physicians, which will come, will be gone, I think in a 5 years time, but still with this much amount of patients admitted in our hospitals, we need a team to take care, or you can have a clinical pharmacist who can lead a stewardship program and help the hospital in reducing the cost related to antibiotic use, the increased hospitalization, etc. Like all the hospitals that are here, all the managements representatives who are here, we all have a good clinical pharmacist run program also, right? So you understand the value we can add, but the thing is, we need a lot of training, because we are also in our nascent stages, and we are trying to gap that bridge so that as soon as the graduation is over, we will be able to take care of the needs the hospital is looking for, and we will be able to contribute in a big way in reducing the antimicrobial related costs for the hospital.
Thank you, Grace. In Apollo, we have got a big team of infectious disease physicians. Even then, the clinical pharmacists have become, inevitable part of antimicrobial stewardship. You're making an enormous contribution. I think, and you have got a large number of PharmDs in the country today. If you help in all the hospitals, appoint your PharmDs, and then you'll be of, a good contribution to all our hospitals. And we have got senior management experts as panelists here. And probably this is your good opportunity to, to tell us how much you will be useful. Thanks a lot. Thanks a lot for that.
So I would like to just add one more point. All these hospitals right now, the clinical pharmacists are in the tertiary care hospitals, right? Nobody is there in the secondary level or the primary level hospital. There are also a lot of issues is being going on. So if the tertiary care hospitals can train some good clinical pharmacists to take care of the secondary and the primary care hospitals as well, because the salary wise it's not going to be a big budget on you, and that is because antimicrobial stewardship has to be wholesome. Like we have to holistically approach it. So that way also, if we can utilize a clinical pharmacy force to ensure that India's global burden for antimicrobial resistance is reduced at every hospital level, that also would be something that we can work on.
Yeah, we have got Dr. Sunil Kedarpal here. Dr. Sunil Kedarpal, the director of HPI. Dr. Sunil, Dr. Grace Dawn, our PharmD clinical pharmacist, has made a request to the hospital management that they are willing to help the secondary and primary hospital, provided we train them, and that they will be able to help other hospitals. So, Dr. Sunil, how can we, make sure that that will happen?
Yeah, I think first of all, we need to see what are the challenges, faced by the hospitals and also the administrators and all the stakeholders. And challenges are different for different types of hospitals. Like hospitals which are located in urban areas and rural areas will have different kind of challenges. Also, the size of the hospital and the level of care provided, as rightly mentioned by her, whether it is primary, secondary, tertiary, or quaternary. And for example, challenges with the smaller hospitals are that they have difficulties in forming a multidisciplinary team, and they often have an inadequate funding is again a problem. And also the microbiology labs, even if it is available, the quality assurance challenges are there. So it is found that the tertiary care healthcare facilities in urban areas and those hospitals who are NABH or JCI accredited, and in smaller hospitals or primary healthcare centers, the implementation of AMS program is always at the back seat. Like I think she very rightly mentioned that tertiary care, because they are accredited hospitals, most of them, and they have all the NABH standards in place, and compliance is, even if it is not 100%, there is a good amount of compliance. So the focus should be on smaller healthcare facilities in low and middle income in country settings. Of course, this includes our country. And AHPI, it represents the majority of the healthcare institutions in the country. And we have about 20,000 odd members across all the states. We have 20 state chapters spread across across the country, and each state has its own executive committee with the president, vice president, and the secretary, and the executive committee members. So we have a reach of smaller hospitals like the primary and secondary care hospital. So we can, once we frame the policy, and once your organization decides on, after this brainstorming session, maybe we evolve a strategy to how to combat this menace of AMR. We can always disseminate the information and spread it to the smaller healthcare facilities in the country. We can facilitate that. AHPI can facilitate.
Yeah. Thank you, Dr. Sunil. That will be an excellent, strategy by HPI. You've got such a large network of the hospitals and influential body. If you all collaborate together, success model of all the big hospitals, if you're able to extrapolate to smaller hospital, that will be a great initiative. We have Dr. Uma Nambia here. Dr. Uma.
Oh, wow. Okay.
Ma'am, thanks for joining.
Or students of friends.
Ma'am, you worked as a CEO of several top Indian hospitals over the last 2 decades. And you are also a neurosurgeon by training. Infection control and AMS departments don't bring any direct income to the hospitals. At the same time, infection control service needs a lot of workforce and resources. The top institutions have understood this and invested in infection control and AMS departments. What will be your message to those hospitals, especially smaller private hospitals, that are hesitant to invest in infection control and AMS department?
So Dr. Ghafoor, first of all, let me thank you for having me on this panel. And you know very well that infection control is very, very close to my heart, as a surgeon as well as an administrator, where I've been very focused on making sure that we follow, rational infection control in the hospitals. Coming to the smaller private hospitals, it's not that the owners or the doctors working there are unaware of this. But what they don't have is, when I joined, Dr. Kethrapal was mentioning about how sometimes they lack funding, they lack resources. Not just funding, they don't have access to a good microbiologist. They don't have access to good microbiology reports, labs, okay, and a consolidated opinion by an infection control team. It is not something that a small private hospital can afford to have. Let's put it, because at the end of the day, ROI is something that every owner will look at it. And if it's owned by doctors, they also need to have resources to run the hospitals. my view on this, I mean, I've been thinking is, can the larger hospitals and bodies like your trust and organizations like AHPI, can we create an ecosystem whereby we can handhold them and give these resources to them at a very, very low cost? We can spread the help and use the economies of scale of the large number of small hospitals and a very dedicated team of the infection control personnel who can guide them on the right policies. And then because you have the ecosystem under control, even the team that's doing it has better idea of what are the prevalent infections, what are the growing trends, the resistance threat that are growing organisms in one part of the city versus the other, and probably have a better way of controlling this. I feel that as organizations that can afford it, I think we will be doing this as a service. There would be small payment as well. I mean, you actually have the infection control department will become a business head, by collaborating with other people and providing the service. I mean, that's my view on this, because otherwise it's very, very difficult to tell a small hospital owner, listen, you need to spend this much money on doing this. They understand very well the number of patients they're losing, or whatever is happening because of the dangers of the rampant infection. But how is it that we can help them is what we should think.
Thank you, ma'am. Yes, HPI can be the organization coordinating AMS activities for the country, being the largest coordinating organization. Dr. Narayan Shivakumar,
have a consortium, have a consortium of some of the societies and reach further. That's whether AHPI, CAHO, your organization, some individual hospitals, like that. We should think, we should think of the big picture.
Thank you, ma'am. We have got Dr. Narayan Shivakumar, ma'am. We need your opinion on how can we build the workforce.
So I start off by saying that a very integral part of not just antimicrobial stewardship and appropriate use of antibiotics, but overall the medication management and safety of medication usage, the role played by the clinical pharmacists is tremendous. They make a whole lot of difference. And in fact, for a very long time for us, all our hospitals in India have been used to only having the for us pharmacology, pharmacies about the dispensing pharmacists, but now most of us have actually comprehensively understood the importance of having the clinical pharmacists who make so much of a difference. And you're right, not only in the smaller hospitals about they not being able to afford it. I think the larger hospitals also have, like a hospital like us, I'm always looking out for more clinical pharmacists and finding it difficult to recruit them and finding good people available in a place like Bombay. Not very easy to get a good this thing, and we would like to have a comprehensive full team of a department, which is a clinical pharmacist department. There's an opportunity for that. How can we, one is, I wonder if there is a way we can reach out to the organizations which are training them to expand that population, and we could support them by, making our centers where we could help them for internships and such placements. But apart from that, I wonder if there is a second level which could be created, and that second level may not be having the full gamut of that training, but under the trained clinical pharmacists, if we have some, maybe it could be the nurses, or it could be some people who are selected based on some criteria, and they undergo a slightly more limited training, which could be like a certification or something like we do it for the critical care nursing and all of that, where one level we equip them with knowledge to be able to monitor, let's say specifically for the antibiotics, and place them in different sections of the wards and ICU. So in that way, we would have more hands available. And in such training, if with organizations and with private hospitals, if there needs to be a partnership, even we would be more than happy to get involved in such activities for doing any kind of capacity building. So in our own hospital, for example, we have a large hospital and we have a small hospital within the same city. So one of the things which we do is, for the larger hospital, it's a little bit more easy to get clinical pharmacists. So we get in some, and then we identify some nursing staff and give them one level of training by the clinical pharmacists, train them on some key vital areas, and use our own this extended team to cover the smaller hospitals as well. Like everybody's mentioned, sometimes it's difficult to find enough to be able to find enough financials to have a smaller hospital having an independent resource. But I would think that there is also a challenge of having a shortage of people. So both of these can be addressed if we can have some other section. And I think it's mostly the nurses who can be put through some kind of a certification course, and like an apprentice to a clinical pharmacist or whatever, something like that we could call them, can be used to expand this task force, which is an extremely integral part of good medication management overall, as well as specific to the antimicrobial stewardship and appropriate antibiotic usage program.
Thank you, ma'am, for stressing the importance of teamwork. The doctors, nurses, clinical pharmacists, management, IT, we all work together to make it a success in all our hospitals in different groups. Dr. Ilan Kumaran, Dr. Ilan, you work in a special unit, liver transplant center. You've got a very large liver transplant center, and you've got a big name, Professor Mohammad Rilla, to guide you. What are the special challenges you face, and how does Dr. Professor Rilla's big name help you to implement that program? Because big names always help. In our setup, our chairman, Dr. PC Reddy's big name, helped us a lot. And Rohini next session will explain in detail how that helped us. But in your center, how did that name help, and what are the challenges you face? How you overcome it?
Hello, can you hear me?
Yes.
Hello.
Yeah, we can hear you, Ilan. We can.
Yeah, I'm sorry. I think got interrupted. That's a good question, Dr. Gafur. So not only our hospitals, many hospitals of our caliber or our size will be facing one unique challenge, I feel, because being a quaternary referral center, we do get patients not only from neighborhood, we do get patients from all across the country, from outside the country also, which means that most of our patients got getting treated by some other doctor in some other place. And many of the patients used to get admitted in some specific centers where there is a possibility that there is no control of what antibiotics are being used, which means when they land up in our center, they are coming with a ticking time bomb in terms of antibiotic resistance. This is one of the major unique challenge we are facing at this point of time. To overcome, see, for example, if we get a patient, say from Bangladesh or some other country where there is no AMS program, they'll end up here. And if we need to do an urgent liver transplantation, it's going to be very tricky on this kind of patients. At the same time, if we have adequate time interval between the time of arrival and the time of transplantation, we may be able to optimize and put things into place. I think this is one of the major challenges we are facing at this point of time. At the same time, we do have a strong control on screening these kind of patients to find out what kind of infections they are having. We do thorough antibiogram on these patients. If you look at the challenges internally, you have rightly said that we have a big name. He's the chairman of the institute, and I am an intensivist. I'm the CEO. So to get the doctors buy-in locally is a bit more easier compared to any other hospitals. So we have liver institute and we have non-liver institutes. So we have many doctors working in our hospital. To implement good AMS program, we need doctors buy-in. I think that's the most important bit. especially in private sector versus government sectors. I feel it may be easy to implement these kind of programs in a government sector than a private sector, where you have many more big names where they will have some egoistic issues. It's difficult to control them. It's maybe difficult for anybody to go and say, a doctor, please don't use meropenem. You have to get approval from some local consultants to use meropenem. I'm sure they'll get offended. This can be one of the challenges. I think the big name like Professor Rela, this issue will be completely resolved. If he says this program needs to be implemented, doctors will follow, because we have shown in many occasions that we are for patients, and then we have invested a huge amount of money in creating infrastructures, getting manpower, human resources to solve this issue, and then bring this AMS program very successful. I think having a big name, always it's very useful to implement such a highly efficient programs, I would say.
Thank you, Alan. Very, very useful comments. We have Dr. Vasant Nagwekar, who is a senior infectious disease consultant in Mumbai. He's also the deputy managing trustee of our AMR Declaration Trust. Dr. Nagwekar?
Yes, sir. Okay.
How can our AMR Trust help the hospital in the country to tackle the AMR challenge by collaborating with all the other relevant stakeholders?
I think to begin with, I think the program, I think we had a program with the MBBS students, that is a Rotrac Medic Group. So I think spreading the education of AMR and AMSP, not after the doctors who have graduated coming. So I think our trust aim is also to sensitize the teaching hospitals where your undergraduate courses. So I think to implement this AMSP program and even the AMR to teach them, because I do remember when I graduated, whether AMS and AMR, anything of that was taught, and even now I don't think that so much of relevance is being given. So I think our trust aim also is to have this education spread, how to begin right from the medical school. So that is, I think, very, very important. Instead of having it in the tertiary, so our aim is to right from the budding, from the root cause, to start that. So that is what our first aim is. Second is, I think, education of the healthcare providers. That is what we are doing, webinars and having CMEs. To apart from that, having bringing the major stakeholders, that is clinicians, which is a very difficult task for the administrator as well as the IDE consultant or anybody. Just rolling out a program does not, even if the ID consultant wants to implement a very strong antimicrobial stewardship program, I will tell you that unless the administration is not supportive or not very strong enough, just to have AMSP or AMR on the paper is not good enough. But to have that implemented strongly is what is required. And I can give an example of myself when with Dr. Narayani, when I was at Fortis. And, when we implemented the AMS program was going on, but when we had a more stronger AMS program to be implemented, all the majority of the clinicians were not happy with that. Suddenly some restriction is going to be there. But I think Dr. Narayani was very, very strong, and she questioned all the clinicians why this program should not be implemented. And I think over a period of time, we saw that over a period of 1 year's time, we saw that the program went so stronger that all the clinicians were in favor of that. And in fact, that was a clinician's buy-in. So I think it's very, very important that just not having AMR or AMSP program just on the paper and in the hospital and for NABH accreditation. I think it should be a stronger clinical, more practical, and has to be persuaded by the administrators very strongly along with the ID team. It should be a teamwork along with ID team, microbiologists, clinicians, your pharmacist. I think all this together, the IT team, even though I think the information technology also plays a very major role in the AMSP program, because it's a teamwork of 7 or 8 different departments together. Then you can have this program strongly rolled out. Apart from that, I think to have a very, very accurate diagnosis, you have to have a good lab support for your patients, where your clinical diagnosis is been by your microbiologist team or your pathologist team has been given. So I think every lab should upgrade themselves with the newer diagnostics like the BCID2 panel, or even for that matter NGS. Because otherwise, when you have an infected tissue, but you don't get an organism, and you keep on changing antibiotics after antibiotics, and finally we only land up with more resistance. I think together all this, we can, as a AMR trust, try to educate the various teams, right from medical school to the highest position of the hospitals.
Thank you, Nagwekar. We need tough, supporting senior management members. Dr. Uma Nambiar, I know that, I know her for a long time. She's a tough problem solver. I heard a story of Dr. Uma Nambiar, had a problem with the trade unions in Mumbai when she was working there. Her an encounter with the famous, Baltakare Sahib. Dr. Uma, can you just explain how you solve the problem by being tough and being lenient?
So, this is in a new hospital, it's easier when you're setting up a new hospital. This becomes an easy problem because you make your antibiotic policy, you have a good infection control in charge, and you also insist on training all the users and also all the doctors who are coming in new. You're trying to create a culture. It becomes quite easy because everyone wants to work together. In an already existing hospital, which has been running for a few years, and then you want to change the practice, that change management is very difficult. There are a couple of reasons. One is that every doctor has his own favorite as far as antibiotics are concerned. They literally start to write that, and they don't, even give it a thought that I'm doing more harm to my patient by doing this, by indulging in this practice. Many surgeons, they will write groups of antibiotics which actually should not be written together. They'll write number of antibiotics, and they feel that if I have more number of antibiotics, the better it is for the patient. Especially if I put an implant, then I'm adding one more. I mean, it's literally, wearing blinkers and thinking that antibiotic is some kind of a magic wand. I put an implant and then I put 2-3 antibiotics, patient will not have infection. It's quite the contrary, so discussing with them and what I found is, these are not discussions that you cannot just put down a rule and saying this is the only thing you can do. I've not found that very useful. I prefer to sit with a doctor over a cup of coffee and say, look, we can do this better, and let's try it this way. I'm sure if you have a problem, we are here to sort it out. I will make sure that it's addressed and all your concerns will be addressed, and then take it with one person at a time. It takes a little time, but it gets done. You will get there, but you will have to use multiple strategies, discuss with individual doctors and understand why they're doing it. I mean, if they're following some international practice over the years, it could simply be because they have not thought about it. I mean, if I'm during my training, if I'm using a set of 2 antibiotics for my perioperative prophylaxis, the chances are I'll use it the rest of my life unless somebody tells me to change it. And that's exactly how and I've seen that amongst my colleagues when I was practicing as a surgeon. I myself, followed a lot of these kind of, I carried these notions in my head and did that. So I have seen both sides. I have also been a culprit on the other side when I was a practicing clinician of following just those 2 drugs which I knew about. I didn't bother to learn about a third drug. I didn't discuss with my microbiologist well enough, or we didn't have so many ID specialists at that time, and didn't educate myself. So a lot of it is also lack of education. The best education many of us have after we start practice, especially if you're a busy practitioner, is what come to you from a medical rep. I mean, that's like even worse. So I think these are all these multiple problems, and each one of us is afflicted by a different part of the syndrome. It's not all of us have all the bad traits in us, but it's a mix of all these things. And in a hospital where you have multiple consultants working, this is the milieu. And you need to really understand and talk it out and rationalize it and get this going. See, at the end of the day, when every doctor wants the best for his patient, right? And once you are able to convince them that this is what makes sense, and I'm sure as an ID specialist, you would have seen that right in the beginning of your practice, nobody, and certainly no surgeon, would have come and discussed with you. And today, I'm sure before they, they handle a difficult case, they probably consult with you as to how to manage the infection. So that's how it happens. I think that's been my my experience everywhere in all the hospitals that I've managed so far.
Thank you, ma'am, for your very useful comments. It's time to close our first session, and the respected panelists, please, if feasible, I know you're all busy. If feasible, stay back for the second session. And thank you, Dr. Sunil Khetabal from HPI, Professor Ilan Kalyamurthy from Rela Institute, Dr. Narayani Shivakumar, and Dr. Uma Nambiar, Dr. Shadullah, and Dr. Anu Warrior. And we would like to have you for the follow-up meetings in the coming months. Please join us for the follow-up meetings. Thanks a lot. And let's move on to the second panel discussion. The greater the obstacle, the more glory overcoming. And we have eminent panelists from private and government sector. We have Dr. Rajiv Sadanandan, who is the former Additional Chief Secretary for Health from Kerala State. And we have Dr. K. Kolandaswamy, who is a public health expert and former Director of Health Services from Tamil Nadu. And we have Dr. Nusrat Shafiq, who is from the Department of Pharmacology, PGI, Chandigarh. And we have Dr. Todi, who is the Director of Critical Care from Amri Hospital, Kolkata. And we have Dr. Clive Fernandez, who is a Group Clinical Director, Wakad Hospital, Mumbai. And we have got Dr. Taran Gyanchandani, CEO of Reliance Foundation Hospital, Mumbai. And we will be having Dr. Vivek Talukdar, CEO of Gleneagles Global, Mumbai. And then we have Dr. Rohini Sridhar, who is a Senior Vice President of Apollo Hospital, Chennai. And Dr. Rajiv.
Yes, Dr. Gopal. Yeah.
Thanks for joining. As a health secretary in Kerala, you are one of the most experienced and most active state health secretaries with special interest in the field of AMR and AMS. And we would like to hear from your vast experience on the challenges at state level in implementing AMR programs, and how can we overcome those challenges?
Thank you, Dr. Gafar, for the kind words. I'm not sure they are fully deserved, but thank you anyway. It's the big problem in AMR is its lack of salience. Its importance is not well realized by policymakers. And these days, after having left government, I work with a not-for-profit research company that tries to work on health systems, and we find it very difficult to make it important for health secretaries to understand the importance of antimicrobial resistance. The best solution for that is actually to get the data. If you're able to collect the data and demonstrate the impact of, the presence or the presence of antimicrobial resistance in your own hospitals, it becomes very immediate, because if from your different, let's say government hospitals, we actually started with government hospitals. The moment you start collecting that data at the hospital level and have that discussed at the hospital, heads of departments meeting, and then you bring it to the state level, and then suddenly you start realizing, God, this is quite a dangerous situation. I remember a situation in which we had a case of VRE, and then you start losing sleep. So it's important. The important thing is to collect the data and then bring it in, and then get it as widely spread as possible. We started with tertiary hospitals in government sector. Then we brought in the corporate hospitals in the state. and then the laboratories in the state, all of them came together because this is something that everybody realizes intuitively. And the moment you're able to arrange people to come together, then everybody collaborates. And I'm happy to see that since then, Kerala has now gone on to start looking for antimicrobial resistance at community level using a hub and spoke approach, and has now produced these reports at the district level. So to me, the important thing is to make it obvious with the collection of data, and that is where the microbiologists and ID specialists can persuade the state government to bring this data together, because nothing is as dramatic as data showing you where the resistance is. I'll stop there.
Thank you, sir. We have Dr. Kolanda Swami, former director of DHS from Tamil Nadu. So you are a public health expert and former DHS in the state. How can we implement AMS program in all hospitals at the state level?
Good evening to all of you. Actually, we did a study with the help of the CDC and NCDC New Delhi in 2 districts, Coimbatore and Tirunelveli districts. It gave us a rich experience. So whatever the reasons, the so far identified almost matched in the study also. So that is the simple procedures like hand wash, the hospital infection control practices, and properly doing the antibiogram, mapping the antibiogram and using inappropriate antibiotics. But for all these things, we used additionally, the project funded 2 nurses. So they were able to understand, they were trained, both the nurses had been trained, and they used to visit to different hospitals, and different programs, orientation programs had been conducted for the doctors and nurses across the 2 districts. And people are very responsive, and the findings also very similar to the findings elsewhere. The very, very simple procedures like hand wash, very simple training. So how to do the sterilization, infection control practices, how to audit the hospital infections, and the antibiogram discussion, that made a lot of change, including the practices of sterilizing the sterile procedures to be followed in urinary, to control the urinary tract infection. Of course, that was one of the major problem in both the district. So what we have gained the experience, we need to have dedicated infection control nurse in every hospital, at least in a major hospital, 100-bed plus hospitals. But that is a real challenge. We proposed in the NHM also. And what had happened, then subsequently the COVID-19 came, and the whole thing, the AMR state nodal officer had also been nominated based on the 2017 Delhi declaration. But subsequently, somehow it had not taken off. So although the national task force, the state level nodal officers have been identified, and NABH quality teams are functioning in different hospitals, and several of the government hospitals have already acquired the NABH certification. But despite all those things, still there's a lot of challenges in implementing. But in my opinion, unless we appoint a dedicated nurse exclusively, that is the case even in our neighboring country, Sri Lanka, where you don't find this much of hospital infections. Even in fact, I'm coming to in a different dimension I am talking. If you look at the 3 diseases, one is dengue. Although it is a vector control, it is a different kind of infection transmission dynamics. So the other 2 are swine flu and COVID-19. You could have noticed across the country, so the COVID-19 the epicenter lies in cities where there is, irrespective of the population density or irrespective of the road or train connectivity, that had been, you had seen the lockdown also. The travel also had been restricted, but we could have observed both in swine flu as well as in COVID-19, wherever there are large number of hospitals, these cities, the towns, acted as a major, the epicenters for in other words, the hospitals are the source of infection, very clearly indicating that the infection control procedures are not being followed. And if we look at the women and children, so they are also, the women and children also mixed up with the general, practically, to putting it in other words, every hospital should have three kinds of, the three categories of the categorization and our segregation. That is one for the infectious diseases, and another for the women and children, and another for the other, maybe the surgical emergency ICU and other thing. So the lot of structural changes that we need to bring in. So that had been brought in for largely for women and children. Then functional process changes also, functional changes also we need to bring. The visitor control, the number of the patient, the attenders, whether the same attender or one or two identified healthy attender continues to be in the hospital for the rest till the patient is discharged. So these kind of issues, a lot of issues are there, both in government as well in the private hospitals. So we need to address. Then one simple thing that we can look forward, particularly the AMR Trust. So we really congratulate the AMR Trust, particularly Dr. Abdul Ghafoor, for single-handedly carrying forward this program. So I am sure that you're setting up a surveillance program. A lot of work has been done individually for the different patients in both private and government hospital. The antibiograms are being done. Say, for example, if you take the cholera, almost for the 40-50 years, the culture and sensitivity is being done by the various government hospitals. The same way, for urinary tract infection and bloodborne infections, a lot of work is being done. But unfortunately, this is not in the formal a kind of registry or a kind of surveillance system. So if you look at the cancer, so we have nominated the Cancer Institute Adayar as the nodal center for cancer registry program. From all pathology labs, from all the radio diagnostic centers, from all the hospitals who are treating the cancer cases. So the reports, the line listing comes to this Adayar Cancer Institute, and every year the annual the cancer registry is published. So in such way, the AMR Trust, maybe in collaboration with this National Institute of Epidemiology, who are already undertaking a national level program for this AMR and this antibiotic stewardship program. So I think that will go a long way in improving it. And also this AMR Trust can set up a website. I don't know whether it is available or not. I have not seen. And set up a website, and the website can act as a resource center. And since there are a lot of experts who are involved in this field, can develop a small online course with some contact sessions with some eminent microbiologists and experts in the field, infectious disease control and public health. A small short, maybe a 3 months or 6 months online course may be started. So a lot of things we need to do, but one positive thing which I would like to bring it here. So in private sector as well in government sector, people are very receptive, and they are willing to listen. And there are a lot of experts who are working independently. We need to network them. We need to bring them together. So I think this kind of work, the AMR Trust can act as a nodal center.
Thank you, sir. AMR Declaration Trust will be more than happy to be collaborating with, all activities and every state on the AMS program. And we have a website already. We have got 7 trustees. We're all actively working together for the cause. We've got a big team of advisors from, so you're one of the advisors, big team of advisors from economists, other healthcare field, and drug developers. They all, give us a lot of support, a lot of moral support. And we had multiple advisory meetings. And Dr. P.V. Ramesh, the former Health Secretary of Andhra Pradesh, was supposed to join this webinar, but he's traveling now. But in future, he'll be attending other meetings, and we will be more than happy to be a part of all the programs. Thank you, sir. And we have Dr. Rohini Sridhar. She's the Senior Vice President of Apollo Hospital Group, and that's a place I work as well. I proudly say that's a place I work. Dr. Rohini.
Yes, Dr. Kapoor, it's an honor and a privilege to be here on this program. And I think we need to wait. Really gratifying to see somebody from Apollo take the lead in this, as I think the institution has also done over the years. So great to be on this panel.
Ma'am, Apollo Group has one of the probably the greatest, largest number of ID physicians than any other hospital group. Does this, the presence of a big team of ID doctors help in successful implementation of the AMS programs in the group?
Yeah, thank you, Dr. Gafoor. I'd like to answer this question in 2 parts. The first part is, of course, having a big team of ID physicians means you have a core group that is completely committed to the concepts of AMS, and that increases the acceptability among other clinical colleagues. If I would say the biggest plus of having an ID team is that it increases the acceptability. And the reason it increases the acceptability is in the clinical scenario of something going south. We know that there is an expert who will be standing by your side, and it gives a lot of reassurance to clinicians that, they will not be left in the lurch if they follow the advice of the ID team. So I think that is a huge and a big plus for us. The second plus is, and I think the people on this panel might not realize, but just the number of antibiotics that are thrown at us as non-specialist clinicians in the antibiogram can be intimidating. In fact, it's very difficult often to even make a sense of the antibiogram that is provided by many of our units. And I think in this, the ID physicians may play a very important role in analyzing all this data and distilling it in a manner that an average non-specialist clinician can see at and make sense and implement. In the final analysis, the non-specialist clinician wants to be told in 1 or 2 sentences what he needs to do in a given situation. And I think that the ID physicians do this the best. So the first one was acceptability, and the second one was analysis. The third and perhaps a very important thing is whatever advances are happening, whatever newer antibiotics are coming into the limelight, we don't want to find out about it from a medical rep. So that is the reality for most of us. We hear these names for the first time when a medical rep walks into our office. So the ID team helps us to keep abreast of the advances that are happening in the field, not just in terms of newer antibiotics, but also in terms of newer diagnostic methodologies, newer definitions for surveillance, newer practices and protocols. And so they play a very important part in making this AMS program successful. So having completed the 3 A's, let me also say that one of the reasons Apollo has so many ID physicians is I think we realize the value that they bring. So it's not that we started out or we were just randomly had so many ID physicians join us. We consciously look for ID physicians. And despite the fact that we have such a large team on board, I think one of the key areas that we have identified as a group-wide priority is to bring more ID physicians on board. So I think this is just a chicken and the egg. We don't know what came first, our commitment to infection-free hospitals, and then our commitment to ID physicians, or our commitment to ID physicians and consequently the importance on keeping our hospitals infection-free. Thank you, Dr. Gul.
Thanks a lot, ma'am. We ID physicians are feeling really honored, Of course, yes, I know how much, Apollo respects us, ID physician. We are active part of all the hospital activities, and we get full freedom to do antimicrobial stewardship and infection control in the hospital. Thanks a lot. We have Dr. Nusrat Shafiq from PGI Chandigarh. She's a clinical pharmacologist and she's in charge of establishing a very successful antimicrobial stewardship program in PGI Chandigarh. Dr. Nusrat, what are the challenges you face and how could you overcome those challenges in a top government, central government institute in the country?
Thank you, Dr. Gopur, for having me on this panel, and thank you all the more for asking me that very specific question. I would like to inform the audience and all my co-panelists that at PGI we have a multidisciplinary team. I mean, I wouldn't want to call myself as an in charge, but it is largely a foot soldier, or I kind of guide the program, and we have a largely pharmacology-driven AMSP program. This is not to say that it is solely owned by them. It has multidisciplinary component comprising of clinical microbiologists. We have with us a lot of surgeons. We have hospital administration and everyone along. So as regards to challenges, when we started nearly 10 years ago, everything was a challenge. To start with, getting a set of people who could work together in a committed manner for a protracted period of time, very patiently and perseverantly, was one big challenge. Second was getting people to accept these people that they are co-partners in helping the outcomes, in helping in improving the outcomes, in bringing a change in our AMR scenario. That was the second big challenge. And third very important challenge was the volumes. I mean, a lot of you would have been trained in government setups and you would be aware that occupancies in certain areas, they run to the tune of 300% occupancy. I mean, and that would be very, very unbelievable for many years. It's how it is. So with volumes come a very different gamut of challenges. Your infection control practices are breached. Your ability to reach out to different corners are become more and more, despite having a very big resource, it becomes a limitation. And then there is volume on the other side. I mean, the staff to cater to these numbers is also very big. You have a very big medical fraternity. I mean, something like CTVS would have 2 to 3 units. And early on, we realized that within these 2 to 3 units for same surgeries, you had 3 different protocols which were running. So at that time, when we started making people antibiotic aware was a big challenge, and AMR was not such a big thing. We had some stray publications here and there about AMR being such an important issue, but it was not perceived as a challenge locally. So that was another thing. And then though everyone was trained, everybody came with a medical background or paramedical background, but when we went around asking the resident about the need for prescribing any antibiotic, the answer universally would be because the consultant told so. And that's where we realized that so many things needed to be changed. And then, as it was pointed out by the first panelist, that data, where were the data? So we had to deal with all this, and it required multi-pronged strategies. I mean, I was very fortunate to have built up this team over a period of time, which took care of different aspects. The way we went about doing this was setting up models in small ways and contextualized models. I mean, I'll give you an example. For example, when we started off, we realized surgical prophylaxis was in a state of absolute disarray. So we started with CTVS. We had a meeting with them, and we showed them what are your different practices for the same surgery and how off the mark they would be regarded in any kind of a medically sound forum. So there were not many takers for our suggestion. But the head of the department came forward and said, okay, you try it out on the set of patients who get operated under me, but on one condition: you follow them up for 6 months, each and every patient. And at the end of 6 months, we'll have a revisit from your team, and you should be able to show that there is not only any increased SSI, or there is no increase in any other kind of infection. They were concerned about everything. So we said, okay, we'll do that for you. And we did that for them. We presented it in their entire department, and then that's how things started rolling. And we had similar such success stories in different areas, to a point when there came a point where we have at the moment prospective audit and feedback, which is carried out in a large proportion of areas within the hospital. And these are carried out on a daily basis. There are regular feedback meetings at the departments. We have dedicated sessions for antimicrobials, which are part of the training program. And they occur right from neonatology to the transplant surgery. So that's the kind of thing we've been able to achieve. But I would want to say all the same that we are still not able to reach out to all the areas. The third thing which has happened is that we have been able to develop contextualized pathways for management. And that we don't do alone. We sit with everyone. Even our treatment guidelines that we formulate, it is such a interactive model that we work on, that people end up thinking that it's their guidelines. So the ownership is with the clinician who is writing those guidelines, and there are extensive training programs for that. The other thing, but I mean, these are some of the challenges and how we overcame them. But we do have certain advantages. We have a very big cadre of medical trainees, and they come in the form of not only medical trainees, we have nursing staff who are training, we have different MSc courses. So we can pool in all these resources for providing us services required for audit and feedback, data collection, analysis, and developing our guidelines, training programs. So that is another advantage. Second big advantage that we have is that we have a very good community medicine and school of public health with us. And this way we are able to now move on to other areas which are in the community. We have civil hospitals, district hospitals, we can navigate through them, and because these are our feeder healthcare setups. Unless and until we get things right there, the people who are wheeled in from these places into our hospitals come with all kinds of prescriptions, interventions, and everything. So those are the kind of advantages also we have. So I think I'll come to other aspects sometime during the course of further discussions. But yeah, that's a brief startup for now. Thank you.
Thank you, Dr. Nusrat. Dr. Nusrat stressed the point of shared ownership, and that's one of the main reasons for success of P. That's a message that we should all senders should appreciate. It's a message of shared ownership, involving everybody and making everybody responsibility. Infection control and antibody stewardship is everybody's responsibility. The antimicrobial stewardship and infection control team coordinates it and leads the program, but it's everybody's responsibility. We have Dr. S.K. Todi. Dr. Todi?
Yeah, Abdul.
Sir. You're one of the most, senior most intensivist in the country, and also you are a hospital administration. I would like to ask you, in a private setup, patient bear the increased cost of care. All AMR meetings, we talk about increased cost of care. But in private hospital, either the patient pay or the insurance companies pay. And then why should we hospitals worry about AMR, especially private hospital? Why should we worry about AMR?
A very pertinent point, Abdul. But over the last few years, we are seeing a very heterogeneous group of patients, the paying status. Like the package patients, the patient in different schemes, they are getting now admitted. And I've seen almost overnight the cost of the care. The hospital is very, very keen to decrease the cost of care in those patients, because there is a ceiling, there is a cap in their payment of the different schemes. The health, we have West Bengal Health Service, Central Government Health Service patients. So that is one aspect, and that is where I think it will reflect good on AMR because the administrators and the managers will also be very keen. The second, you talked about the insurance. I think at the present moment, our insurance, it's not in a very mature state. The insurance were the one which drove the AMR in United States about 15, 20 years back, when they saw the cost of the antibiotics were running sky high and the antibiotic resistance was going up. So they mandated the hospitals to have a very good infection control program, stewardship program. And in fact, they had an advocacy group called Leapfrog Group, which told the insurance companies that these are the things the corporate hospitals need to do. And only the hospitals which comply with these directions, they should be sending their patients. I don't see such kind of a movement. So that is another thing that we can lobby, and asking the insurance company that, look, you don't have that kind of knowledge, but you employ an advocacy group, which will have a knowledgeable people like you, and they will advise them. That will decrease the cost of the insurance company. It is a win-win situation for everybody. The third is the accreditation. The accreditation people, they will have to be little more active. At the present moment, it is on paper only. They just want to see whether you have a policy, whether you have a protocol. And I've seen that is being produced few days before their visit. But what is about the overall compliance, how the processes are going on, they're not very keen on looking at that aspect. And obviously the judiciary, they have to be even more proactive to find out whether if there are so many cases of medical negligence, but I have not seen any cases related to AMR of medical negligence. I have seen medical negligence cases on bed sores, but I'm not seen on AMR. So I think that is where even the patient's knowledge, the family's knowledge needs to go up. So that is one part of it, how the corporate hospitals need to change. The second is, I think all the corporate hospitals need to invest into diagnostic stewardship. We did talk about the antibiotic prophylaxis, the surgical prophylaxis. I was talking to cardiothoracic surgeons, people who are putting pacemakers and all that. Routinely, they cover for MRSAs. They said, look, I'm not very sure about infection control. So why not we do an MRSA screening of the nasal swab? And if that is negative, we don't need to cover. So that kind of a diagnostic stewardship needs to come into play. So that is the second thing. And the third thing we lack a lot is the research. We don't have our own research, as you have tried many times, as regards the outcome. We don't have a very gold standard for diagnosing infection. Neither we have a the cultures are negative many a times. Most of the time they are colonized. So you cannot blame a physician for not giving a particular antibiotic, because that might be challenged. The question is, how long, the duration of antibiotic, can we decrease the duration? As you know, all over the world, the antibiotic duration have come down. But unfortunately for MDR organisms, nobody has shown the whether 5 days is good enough than 10 days for MDR organisms. All the studies are for non-MDR. So that is where I think we need to play a role. So those are the few points I think we need to work on together, and might have to produce some more research and things like that. Over to you, Abdul.
Thank you, sir. You stress the importance of research, our own Indian data, rather than relying on Western guidelines and Western cutoff. We need to develop and design our own research strategies, our own values, and our own guidelines. We definitely need to do that. Dr. Clive Fernandez. Clive?
Yeah, Dr. Abdul, good evening.
Clive, good evening. Good evening. We have got Dr. Clive Fernandez from the WCAD group. Clive, you are a clinical pharmacologist and a hospital administrator. Increased use of high-end antibiotics brings better income to the hospital pharmacies. So why should we rationalize the usage of high-end antibiotic? Don't that reduce the income to the pharmacy?
You really asked me that question?
Yes.
Okay, I don't believe it. Does it bring, so I'll address this question of yours and then I'll put in a different perspective because I've been hearing a lot of the other speakers. So you give me some time for that, So we talked about more income, Dr. Abdul, even if we are sitting in a webinar whose topic is, the top 5 methods and ways a hospital can improve their top lines and EBITDAs. I don't think, anywhere in the top 5, top 10, maybe somewhere in the last 3, they may be okay, try and give high-end antibiotics because we'll make some money there. So for everybody sitting here and a lot of people, there is a lot of audience, I really don't think anybody is doing this thinking of the monetization part. And if there are going to be people, there are going to be a few of them who will do that. For us, when you talk about hospital administrators, I put on a different hat. But then operational efficiencies mean quicker discharges. Let the doctor come in time, see the patient in time. That is where you have your money, not here. Healthcare is something, where people come when they are sick. And, we are supposed to heal them. So income is a byproduct of that. I'm not saying we all open charitable institutions, but, I don't think any administrator worth his salt will ever be sitting in the chair thinking only money. Money will come the right way, not the wrong way, So you examine, you investigate, you treat. So coming to that question of the money part. Now, I was just listening to a lot of what a lot of people said. Dr. Abdul, I know you for how many years? And
15 years, yeah.
15 years when I was working in Apollo, right? That time you all were 3 or 4 clinical ID specialists. So the problem is not presence or absence of ID specialists. The problem is not presence of clinical pharmacologists. The problem is not we need more nurses. You know what we are doing? We are all running around the problem. The problem is the mindset of the prescribing physician. Yes, at no point of time I'm saying an ID specialist does not help. He helps. But now, are you talking about how many of you are there, Dr. Ghafoor, in this country? ID specialists as of today? 25, 30, 35?
30, 40, yeah. 40.
Okay. And you know how many healthcare facilities we have in the country?
100,000.
You just answered it. So, if an ID specialist is the person who is going to get the stewardship program done and resistance is going to go off, there's a lot, to be done. So why I brought this up is, because we have been talking about antibiotic stewardship, antibiotic resistance and all this for the last 20 years, 15 years. Are you right? And let's not think India is bad. As a consultant with JCI, I've been to over 45 countries. Everybody is struggling with the same thing. The problem here is the mindset of the prescribing physician, the nurse, the clinical pharmacologist, the ID team. These are all the support system. So till we don't get the buy-in of that consultant, I'll tell you my challenges, Dr. Ghafoor. Even today, after implementing a program, linking it to their ongoing evaluations and all, there are doctors who at the end of the day tell me, but sir, I have to give this because, the culture report may not be positive. Now, there are reasons why we go. So then they have written a book, Smart Physicians, and all physicians are smart. So you are writing a book, why you should do antimicrobial stewardship. They have written a book, 101 reasons why not to, and they'll give you, there is sepsis, the serum, the procalcitonin is high, blah, blah, blah. So coming back to the point, I think it is the primary physician who has to be educated. How many panelists you have got on this right now? When I looked at your panelists, it was 14. And when I look at them, I think apart from Dr. Todi, all the others are the people who are good. All of us are the administrators, and the people who are going to talk about it. We really don't have people here who are actually prescribing. It's the time they should be part of this. They should understand why this is important. And I just wanted, Dr. Todi talked about accreditation, so I want to bring it up. And somebody talked about data. Data is good, but we have got into that whole stage, and I agree with Dr. Todi, data allow. This is not for NABH. This is not for accreditation. Let us not put it on accreditation. Today in Mumbai, and Dr. Vasant will agree with me, Dr. Tarang will agree with me, Vivek will agree with me. We have red lights. The red light, I call it the red light syndrome. We have red lights. When it's red, you're supposed to stop. That is the quality bit. We have the constable who's the accreditation. जब तक वो पुलिस वाला नहीं दिखेगा, हम रुकेंगे ही नहीं. क्यों? Red light था ना वहाँ पे. See, let us never ever say, let accreditation crack the whip. Accreditations are supposed to be descriptory. They say you have a program. They say you have an evidence-based program. The day we say, कि accreditations have to crack the whip, finish. जो थोड़ा बहुत आपने 15 साल में किया है ना, वो भी बाहर हो जाएगा. So that is one thing. So we have a lot of data. Healthcare administrators are here. Till I don't see 50% of this panel, the people who are prescribing, because they'll give you their side of the picture. I'll end it with, I was in the AHPI conference in Jaipur last week. One of the assessors, I'm just not taking his name, a very good friend of ours, he said he was actually auditing one place and, TKR ka patient tha. And he looked at the drug chart. Now see, as a quality auditor, you don't question, why have you given? He went and did that which was good. He was sharing the example. There was meropenem written. Now, as a quality person, you'll see, okay, drug hai, dose hai, route hai, frequency hai, whatever. If you're looking at the antibiotic stewardship or the high-end antibiotics, you might look for the culture. He just asked him, why have you prescribed meropenem? And then there was another high-end there. So the doctor, that orthopedician actually said, कि मैंने तो ऐसे इसलिए किया क्योंकि मैं ऐसे ही करता हूँ. Then, he saw multivitamins. And he said, no, but I'm trained to do that. Then he saw a 3-liter saline given. So I agree, we have to, now go back to the colleges. We are talking about nurses. Why not train medical students? This is where we have to go. This is whom we have to train. So, that's it, my point, Dr. Abdul. The team, every team, we have a team of, 11 people, but there has to be a captain. You are the IT specialist. I am the administrator. There is a nurse. But the man who is to prescribing has to be an important person here. Thank you.
Thank you, Dr. Clive. The AMR Declaration Trust, we work only on the field of AMR, and we conduct meetings for various stakeholders. And we already conducted multiple meetings for prescribers. And, prescribers are always important. We'll be conducting meetings, but you administrators play a great role in implementation. So, that's why administrators are very important. Dr. Tarang Jantardani. Dr. Tarang?
Yes, Dr. Abdul. Good afternoon.
Thank you. Thanks a lot for joining. I would like to ask a question. In the United States and many other Western countries, insurance companies don't pay for the cost of healthcare associated infections. In India, insurance companies do not follow this rule so far. Is there any strategic rule from the insurance company side why they don't really, concentrate on HAIs in an Indian setup? And if they do, is that good for us hospitals? Because in America, definitely is not good for our hospitals, and we infection control specialists always tend to modify the guidelines to help the hospital group. So why insurance companies in India are not discussing that? And if they do, is that good for us hospitals or not good for us hospitals?
So thank you so much. My input on this is Dr. Abdul and all the delegates here is that, well, in India, I think insurance companies are, there's a lot of competition. And if they don't cover our infections, which the patients acquire in the hospital, or prolonged hospital stay related to infections, then half of them will not be able to actually cover the half of the stay of the patients. And hence, people will not even take those policies. So this can actually become a area where the consumer or the customer or the patient or the family may not choose that insurance provider. The most important thing is that in US, in spite of the fact that they don't have the cover for hospital-acquired infection, but still their clinical outcomes are not as good as compared to many of the Western countries like Norway, Netherlands, Australia, New Zealand. And this is also in spite of the fact that the US spends almost 18% of their GDP on the healthcare cost, vis-a-vis 9% that Australia or New Zealand spends, or 8.8% that Norway and Netherlands spends. So I think the answer to the question is there is no, the grass is always greener on the other side, and world is never equal. So I think what we need to do is we need to find a balance. While US policies have a system to moderate the use of antibiotics, but at the same time not covering the cost harms only one person, and that's the patient. So I think in all fairness, every country has to cover the cost for the patient to get the right treatment. But at the same time, they need to have a regulatory framework between the ID physician, between the treating physician and the primary care physician who is sitting in the community, to ensure that the antibiotics are not, number one, abused. Number two, they are given as per the antimicrobiograms of the hospital and the country. And at the same time, the insurance company should have a system that they reimburse the cost if all these criteria are followed. So in India also, I can't say that insurance companies should not cover, then many of our people will just die. I think today they are surviving because somewhere insurance partners are paying, at least covering that cost of treatment wherever it is available. Because in India, unlike US and other Western countries, the accessibility of the antibiotics today is a problem. There is no equity in the distribution of antibiotics. You're sitting in the Bombay, you will get antibiotics. But if you're sitting in interiors of Maharashtra, you may not even get basic antibiotics. So we have a problem here of lack of equity. So first of all, we have to tackle that. Second is, if the insurance is covering the cost, they should cover the cost, but they should make a caveat that when they the underwriters, they look into, they audit the insurance files of the patient, they should put a criteria that antibiotic has been prescribed based on what is the flora of the hospital. Second is, it is prescribed by the infectious disease consultant who has ensured that he will not abuse the antibiotic, will not stop it early, will not just prolong it for the sake of it. And it also has to take the primary care physician in the community in the tow, so that the length of stay of the patient is reduced, the outcomes are better. And even I would like to say that even the question that you asked Mr. Clive earlier, no hospital benefits with prolonged stay of patient. Rather, we want the patients to go home faster because that will help the turnovers of the hospital faster. So following this mechanism will even help the hospital administration to ensure that the patients go home faster, they can serve more patients. So it will be a win-win for everybody. And as I said, we have to find middle ground. So not having insurance cover versus having insurance cover, having is better, but with certain caveats.
Thank you, Dr. Tarang, for stressing the point for the sake of the audience. We hospitals want our patients to go home fast. We don't benefit from prolonged hospital stay. And as Dr. Tarang has stressed, an Indian healthcare system is different, and our insurance companies should not even think of, even thinking of following the American system of non-payment. And our insurance companies must pay. They can insist all the hospital they cover must follow the best infection control and antibiotic stewardship standard to the best possible extent. Thank you, Dr. Tarang.
Before you ask your next question, I wanted to put one line in, just, you can expunge it from the records. After day 3 or day 3.5, there are no investigations and medications actually prescribed,
So actually, by the time a hospital-acquired infection is developed, the insurance is over, actually, Dr. Vivek?
Good evening. Good evening.
Good evening, Dr. Vivek. Now, whenever we attend all the international infection control and anti-AMR meetings, they always say India's got high AMR rates. But yes, we do agree we have got high AMR rates. But, most of our good hospitals are doing very well, and the hospital-acquired infection rate is low. It's a paradox. High AMR rate, no doubt. But HAI rate is low in our NABH accredited, especially in the good quality hospital. It's a paradox. But we are not projecting that idea at a global level. that our hospitals have got low HAI rate, and shouldn't we concentrate more? Shouldn't we advertise that, low HAI rates in and good Indian hospitals?
So good evening to all the panelists. This is a good question for all of us here. Most of us are from the management teams. So we would be looking forward to advertise. But I'll tell you what I understand about infection control. They're all measurable standards. And being measurable, they're also comparable. And not every hospital is an apple-to-apple comparison. So when you start advertising them, the public views them and starts comparing. And that comparison is never an apple-to-apple comparison. So being because of that negative vibe, some patients start forming opinions about certain hospitals. And principally, I would say, I do not believe that you should be advertising this directly. I actually believe that infection control consists of your input, there is a process, and there is an output. So your input consists of your team, your infection control team, the management will into it, the commitment, the passion of the ID specialist, the pharmacologist, the microbiologist, and then it all leads into a good process in the hospital, in the system, and ultimately resulting into a good output, because output is measured by outcomes and the clinical results and the patient outcomes. The faster the patient moves out, lower loss, and faster recoveries. And ultimately, that's nothing better than a better patient outcome as an advertisement tool for us. So as a matter of fact, most of our hospitals who are the top hospitals across the country talk about our outcomes. And I think it should be that way of talking instead of highlighting our clinical indicators or infection control parameters. I think your outcomes will talk for yourselves. And most of the hospitals, not just in Mumbai, but across India, are doing well wherever your outcomes are there. And your patients are your word of mouth across. So that's it.
Thank you. Yeah. So talking about low HA, at least, advertising may not be as maybe positive and negative aspects. You rightly stressed that point. Dr. Rajiv Sadanandan, sir, are you there?
Yeah, I'm here. Yeah.
Is there any difference in the challenges faced by government institutions and private centers? Because in government centers, availability of antibiotics, availability of funding for AMS programs. What's your experience on that?
I think you're asking the wrong person. I never worked in the private sector, so I wouldn't be able to answer that. But before I go into it, let me comment on two issues that were raised. One, I think you are wrongly reading the US system. One of the most admirable things about the US system is the quality control of hospitals that is done at least by the Medicaid and the Medicare program. And HAI will be suicidal for the reputation of a hospital. So while we may have a lot of problems with the US system, I think something like that, in which we are able to monitor, and not only this, there are lots of other parameters that they monitor very rigorously, including user experience, which I think Indian health system can benefit a lot from. Having tried to put in place at least the basic OECD set of indicators in my hospitals, I mean, people are reluctant to report that. So I think while we may make many claims about how good our hospitals are, I think the accountability standards have to go up. And I think in that, we have a lot to learn from the CME, the US system of administration. The other point that Dr. Clive Fernandez made is, I think, very, very important. What is a cultural environment in which a physician operates? What are the expectations from him by the society? When I joined the sector in the 1990s, amoxicillin was a reserve drug. When I left, the sensitivity to amoxicillin in our high-end hospital was 11%. So in between, how did this change happen? So halfway through, we found that when we are looking at what primary care physicians want, we were using third-generation cephalosporins as first line of treatment. That is a change that has happened. Now, how did this come about? I don't want to go into it, but we must understand the tendency of the clinician to play it safe. And like we talk in cancer treatment, hit early, hit hard. I think that has now become the norm for the behavioral norm for most clinicians. So I think I agree with Dr. Fernandez. The environment in which clinicians work is something that I think we need to understand while we are talking about this. For example, let us say that what we try to do, like in US, what happens that you put a person on, you admit a patient. Generally, the antibiotic will be administered only after the DST is done. And how many hospitals, at least in government, have the facility for doing this? And I believe that the investment in doing a initial drug sensitivity test would be extremely valuable, even in terms of the cost saved. Now, coming to this question of government hospitals, ideally, in an ideal scenario, government hospitals should be able to provide all the drugs free of cost. But as Dr. Nusrat Shafiq mentioned, government hospitals that operate at at least twice, good hospitals, the places with good reputation, operate at double the capacity. And post-COVID, with all the impoverization that has happened to the community, the load has gone up, and it becomes extremely challenging to have the infection control, etc. Now, in an ideal scenario, government should be able to fund the different range of antibiotics. And as I mentioned before, if we can start with again how good the clinical diagnosis is and prescribe a clinically appropriate antibiotic, but if within 24 to 48 hours we have the sensitivity results, it should be possible for the government clinician to escalate or de-escalate. We normally talk about de-escalation, but not escalating itself is also is equally bad. So that opportunity being there is important. Secondly, lots of people mentioned about the surgical prophylaxis. Because of the huge load on the government hospitals with surgeries, many of you from corporate hospitals would be scandalized by the loads of the loads that government hospitals handle. So surgeons tend to be cautious and I would say overprescribed. And when you look at the kind of antibiotics that are prescribed, that playing it safe is again something that I see. Having said that, when we took our hospitals through the NABH accreditation program, something we realized was that everybody, it's not enough that the clinician is involved, right from the sweeper down to the the superintendent have to be involved in this. Only then it works, and it doesn't cost much. It's more a kind of will to do it and realizing the importance of this, and everyone in the team has to realize that it's important, and you can't just put it on clinicians alone. There are the support that people need, etc., has to be there. So when we look at the amount of money that state government spent on health, if you take out Tamil Nadu and Kerala, the numbers of the amounts are woefully inadequate. And when I look at even we work in some of the fiscally well-off states, 70% of the out-of-pocket expenditure is on drugs, when actually it should be free of cost. The danger with that, and there I don't agree with Dr. Clive Fernandez that there is no greed element that doesn't come in. There certainly there's a small group of unethical doctors who end up prescribing to meet the quota set by the sales reps. You can disagree with me, but that's been my information. After all, Switzerland, Barcelona are good places to visit, so why wouldn't people visit them? Now, but having said that, I agree with what you're saying. No clinician, every clinician would rather see the patient treated and taken out fast, and especially in government. In private hospitals, as you said, you don't make money after day 3 or 3.5. But in government hospitals, in day 3.5, we need the bed for the next patient because there are people lying on the floor. So it's important for antibiotic resistance management and antimicrobial stewardship is extremely important for government hospitals also. And money, Dr. Ghaffar, is not the issue. It's how important it is for the administrators. I'll stop there. Thank you.
Dr. Gafur, can I just answer Dr. Rajiv? Totally with
Sure.
you, sir. Totally with you on that. The Switzerland part will come later, I think. What Dr. Gafur had asked me was, do healthcare administrators and hospitals, benefit as an administrator? He did not ask about the individual physician. Well, I hope he may ask me that question. I'll have something to say there also on that one.
Thank you,
Dr.
Clive.
I'll just make a couple of comments there.
Oh, yes. The question is to you anyway. What are the, financial and other challenges you face from a central government institution?
Yeah, so we really didn't have any funds allocated for antimicrobial stewardship practices, or for that matter, HAI. We had to work with the resources which were available to us. But fortunately, some good things happened at that time. We got some funding through Kayakalp. So some of the things for which we required monetary resources, we could route it through the funds generated through such resource, avenues. The other thing, we look for funds towards for increasing our workforces through innumerable projects that we get as part of our grants. But that's not the backbone of our program. The backbone of our program is usually the staff which is on regular pay roles in different capacities. We do pool in resources. That said, I would like to mention, even in many of the government institutes, not all the drugs are available through the hospital pharmacy. In fact, hospital pharmacy caters to the needs of very few admitted patients. So, but despite that constraint, despite the fact that a lot of payment is out of pocket, availability of drugs is seldom a constraint. At least that's what we've seen. In the peripheral centers, in peripheral institutes, there is a limitation to which your reserve antimicrobials would be available. Most of the infections, they are treated with either ceftriaxone and piperacillin tazobactam. Ceftriaxone predominantly, or any other third generation cephalosporin. This is data based. I mean, we have accumulated this data and we've been able to see that. And one important aspect which got really overlooked in the previous versions of NAP AMR was community level institute healthcare setups. And in the revised NAP AMR that is being paid attention to, there is such an increased high use of antimicrobials there, even in the outpatient settings, for anything third generation oral cephalosporins are prescribed. Availability of oral route of administration for linezolid is a kind of, a bane. So because any staph infection, linezolid is popped in, easy to take. And cefixime is, something like, absence of fever is like cefixime deficiency. That is, presence of fever is considered as cefixime deficiency. So that kind of situation does exist. And it is time that we start percolating into these areas, gathering data from these to drive our policies. There was a remark made about the benefit or otherwise of having HAIs as a marker or as a point of advertisement. I would be really skeptical about that, simply because from some of the exercises that we have done in a conjoined panel, we have seen that there is inadequate labeling of HAIs. HAIs are not called HAIs. There is such a discrepancy between the use of reserve antibiotics. You would see a very high use of neopenam and polymyxins, but on the other hand, you see that HAI rate is reported as very less. So this discrepancy points towards a possibility of underreporting also. Till we get those things right, I think we should refrain from making it as a point of advertisement. So those were the couple of points I thought I would like to add. And with regards to Dr. Fernandez about having the prescribers on board, from day one, it has to be there. Even when we are talking in these fora, or if it is actual field work where we're doing this field work, unless and until your prescribers, not just the senior most prescriber, the trainees are involved with us, it is going to be an exercise in futility. In fact, it is very important to target the trainees because that has a ripple effect. What we have seen is over the last 6-7 years that we have paid a lot of attention to this training of residents across the specialties, and these are bedside trainings in multidisciplinary rounds. They take the message to wherever they go. So there is a lot of dividend that you draw from that kind of involvement with this group of medical experts who are going, if not writing today, will be writing tomorrow. So there were some of the points that I wanted to add.
Yeah. Thank you, Dr. Nusrat. Dr. Kulandaswamy, so you are there?
Yes.
So how can we make all the state governments to spend more on infection control and antimicrobial stewardship? All the states, all Indian states.
Actually, allocation of funds is very much possible, provided the importance of this AMR program and this AIMS program is the advocacy is done properly. That is very important. So at national level, at the state level, so I think that now the advocacy level are the making people to understand the importance of these programs is not adequate. So once that is being done, I think the allocation of funds given this NHM and various other projects, it may not be a major challenge.
So you mentioned that the shortage of fund is not the problem. We need to have advocacy and convincing the bureaucrats and the political leadership.
That is the
point. Thanks, sir. Dr. Todi, so you are there?
Yeah, Abdul.
In your previous discussion, you stressed the importance of our own guidelines, but how can we get it done, especially antimicrobial stewardship infection control area? How can we have our own research, our own guideline? Who will do it and who will coordinate it?
I will give you an example. We talked about health-associated infection surveillance. The way the CDC had gone, because they have access to electronic medical records. So now they say if somebody has a high FiO2 and PEEP and doctor has prescribed an antibiotic, which is all there in the medical record. You can't game it. And so patient has an infection. So, the surveillance definition and the true definition, because if somebody is getting an antibiotic and we are saying I have one VAP in the entire month, and most of my ventilated patients are on antibiotic, there is something wrong. I think so. We need to devise some kind of a surveillance definition in hospitals who do not have electronic medical records. So how to go about it? Now, the societies, the medical societies, including critical care societies, we have a huge network. There are 13,000 members now. So I think registry or a data collection of a network surveillance, that is the way to go. A big observational studies, I think, to do an RCT in our country, given the ethical environment and all, and will be difficult, especially if we have to have no industry involvement. An investigator initiated research without any industry involvement will become a challenge. The funds have to come from somewhere. So I think the societies have to play a big role, the big medical societies. I think the funding are not going into the right direction. The budgeting of these societies, they should have, these are scientific societies, so they should be putting most of their endeavor into doing research from our own data and publishing this research into national and international journals and look into our own problem. And I think it is doable, provided we have intent of the society administrators and the executives to play this. I think that is where we are lacking, because if you have to keep the industry out of it, there are funding agencies, ICMRs and all, but they are not funding AMR. Most of them are on the surveillance programs and looking at the incidence rate and all. That's not going to solve the problem. We know the incidence rate. We know carba-resistant Enterobacteriaceae, it was 30%, now it is 50%, it's going to be 60 next year. But what to do about it? That is where I think even the budgeting of these major national the organization should go, and I think society should play a bigger role. We have a lot of problems which we need our own data, and I think networking and registry at the present moment might be the way out. Over to you, Abdul.
Thank you, sir. Dr. Rohini? Dr. Rohini?
Yes, hi, Dr. Abdul. I'm here.
Ma'am, I asked a question, Dr. Vivek. I'll ask the same question. Yes, Dr. Vivek mentioned it's not a good idea to advertise the low HAA rates because it's different in different hospitals. But still, whichever forum we attend, AMR meeting anywhere, they all believe India has high AMR, and they extrapolate means high AMR, high AMS. And there is definitely a paradox. None of the major Indian hospitals have got high HAI. Compared to anywhere. I worked in UK and now in Chennai, but we don't have high HAI rate. What can we do to, yes, we don't have to advertise, but this paradox, at least we need to convince our medical community and policymakers and the leaderships. How can we do that?
Thank you, Dr. Abdul. I think part of the answer to the question was in your question itself. I think the approach to this has to be largely academic. Taking on the concerns which were discussed by several panelists about the reporting of HAI. I don't think as a country, we are now at a mature state of reporting HAI. If you take the Apollo ecosystem itself, I know that, and the reason I offer you the Apollo ecosystem as an example is that you have the entire spectrum of hospitals. We have big hospitals like Greens or the specialty hospital where you work, where you probably have a very robust mechanism of data collection. You have staff who are extremely well trained and able to analyze and interpret this data and collate it in a meaningful way. But we also have smaller hospitals in the far-flung remote areas like a Karaikudi or a Kakinada, where we are not completely confident about the robustness of the system, understanding, and also you have this constant attrition of a staff able to collate this data for us. So though we are saying HAI reporting, I still think that outside the big centers, this reporting itself can be questioned and may not withstand scrutiny. In fact, within the system itself, when we find that a hospital is consistently reporting no HAIs, it is more often a function of the fact that either their infection control nurse has gone off and they've not had an infection control nurse for a month or so, or their clinical pharmacist is not there. So the causes for this are not really related to good clinical practice. And I think this might be the challenge across the board. So I think I agree with what Dr. Todi said. Can we revisit the definitions? Because as a healthcare administrator, we've been grappling with the difficulty of getting people to report VAEs, to report VAPs. So I think there is a challenge on our hand as to define it in a more effective way so that we can have some oversight on the efficiency of data collection. I think that is critical. And once we get, or simultaneously, while we are putting this together, I think at every academic forum, we need to highlight this paradox. Saying that on one hand, we have high AMRs, which is shown by the last ICMR report, absolutely frightening numbers. And at the same time, say that for the larger hospitals, and in this, I agree completely with Vivek, we are doing more complex work, high-end quaternary work, and undoubtedly delivering the best outcomes. So we have got a handle on HAI, which needs to be communicated, but I would take the academic route, using academic forums more, maybe reaching out to our physicians and telling them that they play a vital role in ensuring that we are able to, sustain this. I think that would be the better way to go rather than to advertise it. The other point that I'd like to make, particularly with reference to HAIs and as a healthcare administrator, is that we tell our teams that in case you have an HAI or an outbreak of HAIs in your hospital, our primary responsibility as health administrators is to create a safe space where this can be discussed. Now, if you're going to advertise it and if there is public reporting, then it tends to drive the bad news underground, which we don't want. I'd rather you put the bad news out there and let's have a discussion about it. And in fact, if we do have a problem, then let's work together to solve the problem. So I think this is a bit premature given where the Indian healthcare ecosystem is to think of advertising or in fact in non-academic forums declaring that we are an infection-free hospital.
Thank you, ma'am. That's very, very thought-provoking, answer from Dr. Rohini and Dr. Vivek, very, very valid point. And, I would like to ask you, I'm an Apollo employee and, and Dr. Pradap Reddy, and he just doesn't belong to our group and he's a giant in the country. So it's applicable to all hospitals, Whenever we had a problem, whenever we had a problem in implementing an infection control antibody stewardship strategy, our senior, including myself, Ram and all, we used to knock on the door of our chairman and we discussed for a long time. And he's there to help us. He quite a number of occasions, big challenges. He was there on the forefront to help us, and that helped. How can we get such supports at other big names in the country? How can we utilize a group of big names in the country for a push for antimicrobial stewardship and infection control strategies to help a national initiative?
So I think that, there are two aspects to this answer. And we know that Dr. Reddy's support is not just for AMS. It is for every difficult problem that every administrator faces in the hospital. I think that's one of the reasons that the Apollo ecosystem has stayed true to his vision. We still deliver quality clinical care wherever we may be. And I think Chairman has an invaluable role to play in that, simply by making and articulating his support for this. So when the support is so explicitly given right at the top, I think it drives the culture within the organization. Second, and I think we saw that you have challenges with getting the teams on board. And in making the resources available, I think Dr. Reddy has a huge role to play. So for example, making clinical pharmacists available across the entire system, making ID professionals available across the system. So this goes to his support and his willingness to see a little further than most of us can see and make all these resources available to us. Having said this, and the point which you made, I think it's something that we need to look at, even just getting them to articulate their support, because these are healthcare leaders, as you said, don't belong to any one organization, but everybody looks at them as leaders who set the tone for what happened. Just to give example, I think our chairman was among the first people to get the COVID vaccine when it was made available. This was simply an example from leading from the front when there was a lot of buzz about, oh, should we take this vaccine? This is an Indian vaccine. In that kind of thing, he's always shown leadership. And I think that getting people like this to publicly articulate support for us, one, gets us eyeballs, gets us attention. So people say, oh, Dr. Reddy has said this, so let's get into it. So I think as an awareness building tool, certainly. And maybe they can also facilitate providing resources for us. When I'm saying resources, I don't mean for Apollo, generally for the whole AMR program. So I think this would be something that is useful. And I'm sure most public figures would be willing to participate in a program of this nature. So I think there's something that the AMR Trust can look at doing.
Thank you, ma'am. Dr. Clive?
Yeah, I'm there.
Yeah, another question related to your field, the pharmacology field. See, India has the second largest number of US FDA approved pharmaceutical manufacturing firms in the world, second only to US. India is a pharmacy for the world. Is it really positive or negative for the strength of antimicrobial stewardship program for the country?
Now, what type of a question this is? Now you're asking me to tell you whether more is good or more is not good. And I don't know, Dr. Rajiv is gone. It looks like we are all in sync, because, okay, so let's talk about the positive. See, when you are the second largest and looking at the quality and the cost and all, it is always good to have more, so we have a better chance of having more molecules, effective molecules. And I won't use the word cheaper. I will use molecules at an affordable rate. The moment we start talking cheap, that's where the rat race begins. But now every coin has another side. And Rajiv sir, this is where we come in. Now, why are antibiotics prescribed? Even in my house today, if I have a throat infection or my neighbor has a throat infection, they don't even call me up, because घर में ही कोई कह देता azithromycin ले लो. Why are these medications so readily available over the counter? So more is not always good. And then now, why exactly is a person writing what he's writing? As Dr. Rajiv said, we have to look beyond the culture sensitivity reports and beyond the clinical, and we have to look at travel histories and where all. So it is good that we are second in, we have so many pharmaceutical companies. We definitely have medications. And, today someone spoke about cost. Believe me, whether it is a government organization or a private organization, let us not say we will differentiate in treatment because of that. So, okay, in a government hospital, you might want to give the same medication, albeit a generic molecule, which you might get cheaper. Because if the infection is going to respond to only a particular, say, a meropenem, you cannot say, okay, because it's a government hospital, you cannot give them a corporate wala. So more is good also and more is not good. So I don't know, it's how we take it. But one thing I wanted to address, when we talked about the previous question, Dr. Rajiv, Dr. Abdul, if I may, when we talked about the data and the display, as most of our, panelists have already said, we really don't know about the data. And I tell my hospital and my teams, and a lot of them are attending. It may sound, like a deja vu to them. Gigo, garbage in. Today, even after 15 years, we are saying we really don't know the exact definitions. When X, Y, and Z, 3 hospitals are measuring surgical site, and time after time their surgical site infections are 0. Is it really 0? Do they know the definition? Do they follow it up the way they have to follow it up? So, there are a lot of other questions that are there. And Dr. Rohini, very nice, she put it very, very well. Apollo is a well-oiled machine, a system. We've all come from there. I've worked there for some time also. If at some point of time the smaller units are not able to emulate the bigger units, what about standalone units? What about other units? So I would just want to say that everybody has to look at this as a real problem of, if we don't use this rationally today, tomorrow when we or our next generation needs it, we won't have it. Till we keep looking at it as, a accreditation thing or this thing, it will not work.
Dr. Rajiv, sir, do you want to add anything?
No, I mean, I think that point has been made. You won't report data if you're not looking for it. So if you don't look for HAI, you will not see them. So the one that has got the worst infection control program will top your list. So it's a very dangerous thing to, because I mean, and I fully agree with what Dr. Rohini said, which is that create a safe space where you can discuss your mistakes. And if you have a system which penalizes mistakes, and then not only here, like most of the results that we try to achieve, the best results are achieved by looking at your failures and your near misses. And unless you create a safe environment by which people can discuss that, people are going to hide it. So I wouldn't recommend that.
Thanks, sir. I think most of you are stressing that point. It's not a good idea to talk much about unless we have the data. Dr. Vivek?
Yes, Dr.
I'll ask you a question. This question was actually meant for Dr. Parag, but she had logged off, and so we ID physicians, I know we have got 40-50 ID physicians in the country, and we believe we play an important role in the antimicrobial stewardship programs. But we consider ourselves poor man's specialty. In America, half of the infectious disease training posts are empty because It's a poor man's specialty. We are not paid well. And even India, we consider, more, not just India, all countries, our specialty, we consider, we are the lowest paid specialty among all. In US, it is the lowest paid. And then next, nephrology, like that, And how can we change that? Because we need more, and we don't get enough students, just like US, there are not enough students in the country willing to take infectious disease. Of course, there are a few posts now. Now with the increasing posts, there are not enough students. And that situation in most countries. How can we change? How can the hospitals encourage more infectious disease physician joining? And how can we make it attractive?
So I'll answer your question on one point. I'll first give you the fact that for me in my hospital, being a more of a transplant hospital, we value the position of the ID specialist. For us, that person is responsible to keep an eye on what's happening in our hospital and to ensure our outcomes. As I mentioned earlier, our outcomes define us. And earlier we had Dr. Vasant. I remember the time when he was associated with us. I can tell you, he had at least I had a year to his problems or his issues. We had our monthly clinical meetings so regularly that everybody knew that when Dr. Vasant puts an issue in the meeting and when I'm there, it would be done at least for the sake of seeing to it that the ID team gets all the support. So when there have been times when we have to talk to consultants, we do it jointly. Dr. Vasant has been taking the lead. And now also I know that whenever the ID specialist talks, we hear him or give them a patient hearing. So we have to give them the importance. As a management, I can say, for me, the ID specialist brings a lot of value to the team. And I hope, and I also know that a lot of our corporate hospitals, which are there in the metros, which are doing so well, also do that. This has to trickle down to our medical colleges. Now, that's where the whole concept has to start, in giving importance to this specialty. And most of us come from government hospitals, government medical colleges. And I think the course is not there as yet so known there that people don't even take it up. And also the infection control practices, sorry to say it, but is not so well practiced as we see it in corporate hospitals. So they come out and come out as doctors, super specialists, without following certain times, at least at the graduate level, the norms which are required, and they're not even trained on it so much. So I think a lot part of the responsibility lies with us as administrators, and also forums like this where we talk and create awareness about ID and infection control.
Thank you, Dr. Vivek, and thanks for all the support you have provided to your infectious disease, Dr. Nagwekar, and thanks to all the senior management staff. Without your support, without your wholehearted support, we can't implement AMS programs. And we have Dr. Nitin Bansal, is an infectious disease consultant at Rajiv Gandhi Hospital, Delhi. He's one of the trustees of AMR Declaration Trust. Dr. Nitin, how can our trust support the AMS programs in all the hospitals in the country? Dr. Nitin? Dr. Nagwekar? Okay.
We have discussed the same point about how AMR Trust can be helpful for to disseminate across India, and how can the AMR Trust be helpful. So I think we discussed about making bringing the major stakeholders, clinicians, administrators, micromanagers together at one front, and having a lot of education on healthcare system providers, webinars, CME. Apart from that, I think what Dr. Vivek said similarly, that the education for AMR Trust is looking at, and we want this AMR and AMS to be started in the medical schools rather than after doctors are graduated and when they come out. So similarly we had a meeting with the sorry for that across medical India, where there are 3,000 students, first and second MBBS students. So AMR Trust did engage with these students and made them part of the program, so that they understand, and and we want to get more and more of these programs with these medical schools, so that the awareness starts from the medical school and not after they have graduated. Also, AMR Trust is also not only looking at the the treatment AMS in AM, but also very important is the diagnostic modality, which is very important. I think if your diagnostic modality, we want to encourage more accurate diagnostic modalities like PCR, NGS, and a lot of the other investigations where you will have more of point of care labs, which will give you a correct diagnosis. I think we're looking at from multiple things and innovations in newer diagnostics, newer medications from India to be manufactured by India for our problems in India, because India is completely different from the Western world. Western grounds, it is and CDFs where there are a lot of drugs available. Whereas India, for MDR, GNVs, we have hardly any drugs available. And AMR Trust is going to sensitize for more drugs to be manufactured and research on these for gram negatives in India, because we have to solve our problems by ourselves. Western people are not going to come and solve our problems.
Thank you, Dr. Nagwekar. We respected panelists, we had a wonderful session, and this is only a brainstorming meeting. We need follow-up meetings, and we need your participation for all the follow-up meetings. Dr. Nagwekar, would you please say the concluding remarks?
So I would thank Dr. Rajiv Sudanandan, Dr. K. Kolaswamy, Dr. Nusrat Sheikh from the Department of Pharmacology, PGH Chandigarh, Dr. S.K. Todi, who just left, Dr. Clive Fernandez from Bukad, Dr. Tarang, I think she left early from RFH, she's the CEO of that hospital, Dr. Vivek Talaulikar, who have worked at Global Hospital, he's CEO of Global Group of Hospitals, Dr. Rohini Sardar from Apollo Hospital. For the wonderful panel discussion, AMR Declaration Trust requests your support in future for all our activities in the AMR field to the support of our country. AMR Declaration Trust has minimal funds. We have received, we just started this trust. We have received a small donation from doctors. However, our resource is not adequate to conduct academic activities. We decided not to charge any of the registration fees so far, whatever program we have conducted, to spread the message. In fact, we have 1,000 people sometimes attending our program, and so that the message goes to a broader audience. We are grateful to the doctors who give their small donations to the trust, pharmaceutical companies such as Sanofi, Gelengen, Converge Biotech, LNK Fusion, and who have provided us with a small unrestricted grant for the webinar, and other companies such as Cipla, Pfizer, from we have requested grants so that we can conduct the webinar without any registration fee. And thanks a lot again for all the panelists for having a wonderful discussion, and I hope it's been fruitful for all of us. Thank you so much.
Thank you. Thank you, Dr. Vasant. Thanks, Dr. Abdul. Thanks to all the panelists.
Thank you, everyone.
Thank you.